Hello, I'm Prof Twelves. I'm Professor of Clinical Cancer Pharmacology and Oncology in Leeds in the UK, and I'm here at the San Antonio Breast Cancer Symposium in 2018.
I'm Giampaolo Bianchini. I work in the San Raffaele Hospital. I work in the breast cancer unit, and I am the head of the clinical and translation immunotherapy research.
As ever, there's lots of interesting research being reported in San Antonio, but what I'd like to focus on in the next few minutes is work around eribulin, which is a compound that I've been particularly closely involved with. And one of the areas that we've been interested in with eribulin is that in addition to its antiproliferative cytotoxic activity, we've seen indications over recent years that it has other effects affecting the remodelling of the tumour vasculature, also affecting EMT, epithelial-mesenchymal translation, and finally effects on migration and metastases. And there's some work here that we've seen at San Antonio that I think is interesting and will enlighten us in these areas.
Yeah, so one of the presentation describes some potential explanation of how eribulin is able to modulate within the tumor these mesenchymal phenotype to revert to the epithelial. Yeah, I would say I would interpret the data on a single experiment provocative, but they very hardly recapitulate what happened in the heterogeneous phenotype of the patient. But I found this very interesting because support all the data that we have that are very strong and robust about not only the activity and the consequence of these potential reversion and making chemo working better after eribulin. What do you think about this?
No, if we step back, the original interest here was when we saw that there was greater impact on overall survival than on progression-free survival with eribulin in breast cancer and in sarcoma. So we've been trying to understand that a little better. And as you say, we have reported here a single cell line, a triple negative cell line exposed to eribulin and showing increased epithelial markers, which may indicate indeed that there is an effect on EMT. I think what was interesting is that the same effect wasn't seen with other microtubule inhibitors. So this isn't a class effect, it appears to be specific to a greater or lesser extent to eribulin. As you say, it's a single observation, but it does map on quite nicely to work that was published earlier this year looking in vivo in a similar way in animals exposed to microtubule inhibitors and looking at the changes in the epithelial and the mesenchymal markers. So in that in vivo study, there was an increase in E-cadherin, the epithelial marker, and a decrease in ZEB3, I think it was, one of the mesenchymal markers in the animals treated with eribulin, and the reverse was seen with paclitaxel. So they're individual pieces of the jigsaw, but I agree that it's interesting. And I find it quite heartening that after treating chemotherapy as being rather a blunt instrument for many years, we see people now trying to understand how chemotherapy really works and look into this in a more sophisticated way.
I completely agree with you. I think that the overall picture about the understanding about the peculiar mechanism of action of eribulin add on every year, and this is another piece of information about the specific mechanism of action. It's very likely that is could be different cell by cell, but the overall mechanism has been very well described. And on this topic, I would like you to comment with me another presentation here of the combination of eribulin with trastuzumab that is not actually the classical indication of the drug, but the data are really provocative for a strong activity. And the real-world data that was presented here, where more than 60% of response rate are extremely high, that are very similar to the data that was presented in the phase 2 trial. So what you think about the use of eribulin outside the standard context, specifically in combination with HER2 targeted agent in HER2 positive disease?
Well, it's not an option for me in the UK because of the NHS reimbursement. We don't have that option.
In Italy, we also have this problem.
But there was no good reason why eribulin shouldn't be combined with trastuzumab. As you say, there was an original phase 2 study headed by Linda Vadat some years ago, which showed a response rate, I think, first line of around 70%.
Yeah.
More recently, there was a Japanese small phase 2 study again, which showed activity. What we haven't seen is a large phase 3 trial. And I suppose this real-world population, although it's not a clinical trial population, gives us a better indication as to whether those benefits in the earlier clinical trials can reasonably be expected in a wider population if you have access to that combination. And certainly, as you say, there is really quite striking concordance with response rates of 55 to 70% in each of these clinical trial and real-world settings. So I think for individuals who've got access to trastuzumab in combination with eribulin, I think those are very reassuring data.
Yeah, it is. Of course, we have to stay to what is approved country by country, and in some countries there are less restriction in what kind of chemotherapy agent can be combined with trastuzumab, the HER2 targeting agent. But I consider this combination, as you mentioned, very, very promising, because again, we know that this is a peculiar drug, and some of the activity that revert the immune suppression can be significant also in the context of HER2. To come off this point, the third presentation that I would like to comment with you is a presentation that describes a combination of eribulin with a new agent. But on general, I would like to make a comment that on the work that are now on place to describe the combination of eribulin with other agents. For instance, the combination with immune checkpoint, epithelial-to-mesenchymal transition is described to be a mechanism of immune escape and is linked to many factors. TGF-beta, that is another important component that eribulin has been described to decrease, is related to immune escape. And so, for instance, this is very likely why the combination with pembrolizumab in the phase 2 trial presented last year in San Antonio in an updated follow-up show very interesting results. And what you think about the data that also has been presented here in San Antonio about the combination of eribulin, actually the trial also combined paclitaxel with a new agent that specifically target the ability of the cell to circulate across the endothelial, targeting type 2 and the vessel that regulate this dissemination. But on the general aspect, to come back to what we was discussing before, also I would like you to comment the potential use of the specific biological effect of eribulin that reducing the epithelial-to-mesenchymal phenotype and TGF-beta reduce the immune escape and general mechanism, and the good data on the combination of pembrolizumab that has been presented last year in San Antonio with an adaptive follow-up, and that looks very promising. So can you just comment about the possibility to use this particular drug in several combinations, really taking the best advantage for the unique mechanism of action?
Well, as you'll be familiar, most of us use sequential monotherapies these days in the treatment of metastatic breast cancer, but I think eribulin may be a particularly interesting combination partner because of these additional biological modes of action. We've discussed already the combination with trastuzumab. We did a study combining with capecitabine some years ago. It was only a phase 2 study, but it showed response rates, progression-free survival that were equivalent to the combination of docetaxel with capecitabine. So that is potentially an interesting combination. And with such a focus on immuno-oncology at the moment, the preliminary data, as you say, of eribulin with pembrolizumab really do look very encouraging. And there is a rationale for combining eribulin with pembrolizumab because of its effect on the tumour microenvironment. The other study that you mentioned, combining chemotherapy with this agent, robastatinib, I think it is, which interacts with the Tie2 kinase and is intended to reduce intravasation of tumour cells, reduce metastasis and invasion, is again an interesting prospect, not least because eribulin does have this effect itself, in addition to the antiproliferative effect, an anti-metastatic effect in preclinical models. So the clinical trial, which is a phase 1 trial, is still at a very preliminary stage. This is a very early report, but the drug robastatinib can be combined with with either paclitaxel or with eribulin. There's evidence of activity, so there's tumour shrinkage seen, and also there's been a reduction in circulating tumour cells and an increase in angiopoietin 1 or 2, which suggests that this is a PD marker to suggest that there is a biological effect in addition to the antiproliferative effect. So I think there's a number of interesting areas to explore for the future. I think we can be more flexible in how we look at chemotherapy and come up with more smart ways of using what are good drugs. Thank you. I hope you found some of these discussions interesting. They're only a part of what is a very big meeting full of lots of interesting information across the whole range of treatments of breast cancer. And thank you again for your attention.
Thank you very much.